So it looks like it's 1:30. We're ready to get started. Welcome to the 2023 Louisiana Healthy Communities Coalition Annual Summit, presented by the LHCC, which is funded by Louisiana Campaign for Tobacco-Free Living and the Louisiana Cancer Control Program. So helpful information today. Again, all participant lines are muted. You are welcome to introduce yourself in the chat, submit your questions. We also have a QA box that is available. Take breaks as you need throughout the summit. We're here from 1:30 to 4. The summit will be recorded and posted on LHCC website. And please tag us and join us at Louisiana HCC, hashtag LHCC 2023. The theme of this year's summit is Louisiana Health Matters, Factors That Make a Difference. My name is Jamie Ciprian. I'm the Senior Regional Manager for the Louisiana Campaign for Tobacco-Free Living, which is a program of the Louisiana Public Health Institute, and also a program of the Louisiana Cancer Research Center. I serve as co-chair for the statewide LHCC along with Nikisha Singleton. Each year, the annual summit is usually hosted by a region in Louisiana to showcase the work that has been done to create healthier communities within the state. But this year is different. Our focus is on the whole state of Louisiana and those social determinants of health that must be factored in if we are to make a healthier Louisiana. Now, Pamela Bradley, who is the TFL Regional Manager in Region 7, will introduce our welcome video. Pamela.
Thank you, Jamie. Hi, I am Pamela Bradley, TFL Region 7 Manager. And again, welcome to the annual LHCC Statewide Summit. We are so glad to share messages today from 3 of the newest comprehensive municipalities. They are Mayor Milton Vining, Ringgold, Louisiana, Mayor John Crow, Farmerville, and Mayor Katrina Evans from Campty, Louisiana. At this time, will you share the welcome video?
Great day, everyone. Welcome to the 2023 Annual Louisiana Healthy Communities Coalition Summit. I'm Milton Vining, and I am honored to be the mayor of Ringgold. It's true what they say, great things come in small packages. In the book of Genesis, it's recorded that God formed man out of the dust of the ground and breathed into his nostrils the breath of life, and man became a living soul. That breath was pure. That breath was holy. That first breath was life-giving. In an effort to return to the basics, on March 9, 2023, Ringgold implemented a comprehensive smoke-free policy, becoming the 7th smoke-free community in Region 7 and the 34th in the state of Louisiana. We are also partnering with one of our local nonprofit organizations to begin our first community garden. Great things are happening in Ringgold. There are lots to see and do in this small town. We're also known for the Slabtown Festival, McCain's Family Farm, Lake Vista State Park, Bonnie and Clyde Ambush Site, Dorchey Historical Museum, and so much more. Stop by and visit us. Once again, welcome and enjoy the summit.
Hello, my name is John Crow, and I'm the mayor of Farmerville, home of beautiful Lake D'Arbonne. Welcome to the Louisiana's Healthiest Community Coalition Summit. We are proud to be a new smoke-free town, 33 on Louisiana's smoke-free map. We invite you to come visit Farmerville, and y'all can come go fishing with the mayor of Farmerville. Thank y'all.
Greetings and welcome to the 2023 Annual Louisiana Healthy Communities Coalition Summit. I am Katrina Evans, Mayor of the great town of Campty. On September the 8th, 2022, Campty became the 32nd community to implement a comprehensive smoke-free policy in our state. The citizens of Candy are proud to be a part of the smoke-free movement and to also have the distinction of being the sixth community to go smoke-free in Region 7. Mark your calendars. Visit us this fall, downtown Campty, for our annual Smoking on the Red Festival. It will be held October the 27th through the 28th, 2023, where you can taste some of the best barbecue in the state of Louisiana.
So a special thank you to each one of our mayors for doing their part along with their communities and making their communities healthier for all. And now we'll hear from one of our co-chairs, Jamie Cyprian. Jamie is the Senior Regional Manager with the Louisiana Campaign for Tobacco-Free Living, a program of the Louisiana Public Health Institute and the Louisiana Cancer Research Center. Jamie graduated magna cum laude with a bachelor's degree in psychology from Grambling State University and recently completed a master's of public health degree from Columbia Southern University. She currently serves as the co-chair of the statewide Louisiana Healthy Communities Coalition, and she serves as the co-chair for the Region 9 Louisiana Healthy Communities Coalition. Jamie, I'm turning it over to you now.
Thank you, Pamela. I'm not sure, is everybody's screen darkened? My screen is darkened. Okay. Thank you. So want to just talk about what the LHCC is. We want healthy communities, Health Louisiana. That is our vision in short. And our mission is to do this, support healthy, thriving communities by mobilizing them to develop and implement policy, system, and environmental changes, or we call them PSE, which are those changes that are sustainable, changes in their environment that just don't go away after one time. Those are the type of changes that we promote that impact the public as a whole and not just one individual. The Louisiana Healthy Communities Coalition, LHCC, as we call it, fights death and disease by going after two of the biggest causes of chronic disease, which are tobacco and obesity. So what is LHCC? Louisiana residents experience high rates of tobacco use. This we know. And obesity and tobacco crosses a whole gamut of other issues, including cancer, chronic diseases. So communities across the state are stepping up to fight tobacco use and obesity. So we do this through healthy policies, improvement of healthy policies to our built environments. How we do this, we provide a network that helps unite, train, support, and leverage communities work through. We have a statewide leadership team that you're seeing today. We also have a connection to local regional LHCCs. So there are regional LHCCs across the state that do the same work, similar work in addressing tobacco use, chronic disease, obesity, and other issues that impact the health of Louisiana. We also provide communication support. We have a communication coordinator, which is Chandria. We also provide community grants, which are minimal grants of $1,000 to $3,000 to impact communities by having those policy systems, environmental change improvements. And today you are here with us that we host our annual summit. This year's theme of the summit is Louisiana Health Matters, Factors That Make a Difference. Along with highlighting the local and state work being done, we will also hear from dynamic speakers who have a passion for improving the health of all of Louisiana. We have collectively experienced many life-altering conditions over the past year, and it's my hope that this summit will serve as a beacon for those who champion better for our state. I will now turn it over to my co-chair, Nikisha, for her remarks. I will introduce Nikisha. Nikisha currently serves as the program manager for Louisiana Cancer Prevention and Control Programs at the Louisiana State University Health Sciences Center in New Orleans. She provides oversight of the Louisiana Comprehensive Cancer Control Program, a CDC initiative, and leads Louisiana's Colorectal Cancer Roundtable. She also serves as co-chair of the Louisiana Healthy Communities Coalition. I present to you Nikisha. Her full bio will be available after the summit.
Thank you, Jamie. Good afternoon, and again, welcome to the 2023 Louisiana Healthy Communities Coalition Summit. Today, you will be learning about the social determinants of health, how they impact your well-being and their impact on our state. Some of the things that you have expressed an interest in learning today include hoping to be inspired by new ideas, wanting to learn more about the social determinants of health, and new and innovative ideas to grow healthier communities. We have a great lineup of speakers who will enlighten us on the determinants of health and their impact in Louisiana. But before I introduce our next speaker, I invite you to watch this video produced by the LHCC that focuses on our two biggest illnesses, tobacco and obesity.
Tobacco and obesity are our biggest killers. Tobacco and obesity make it harder for the body to defend itself. The problem with tobacco is that nicotine is highly addictive, and tobacco companies systematically and deliberately target vulnerable people. Sugar, fats, and processed foods are also addictive, and these food companies also target vulnerable people. In certain neighborhoods, it is hard to access fresh, quality food, and there are limited opportunities for physical activity. The good news is communities can change these conditions by making the healthy choice the easy choice. When things are easy, or people do things by default, it becomes the norm, not the exception. That's why the Louisiana Healthy Communities Coalition, LHCC, supports policy, systems, and environmental changes, known as PSC, to make sure improvements work and that they will last. For example, smoke-free policies mean tobacco users smoke less and non-smokers are protected too. System change happens when a farmer's market gets a SNAP card reader, so lower-income people can buy produce there, which also helps food producers increase their bottom lines. Environmental change happens with complete streets ordinances, so every form of transportation, not just cars, get counted in new infrastructure. Crosswalks, bike lanes, and public transit shelters means everyone can get around to jobs, healthcare, and recreation. Property values even tend to go up. These changes build communities, improving quality of life and health, and literally save lives. That's why the Louisiana Healthy Communities Coalition is here. LHCC connects groups working to improve health in the state by providing state leadership and resources, communications, and annual summit where people learn, share, and get inspired. And last but not least, small grants for groups to create the PSC change in their community they want to see. To find out more about the Louisiana Healthy Communities Coalition and join us, go to www.healthylouisiana.org.
Now I will introduce our next speaker. First, we have Dr. Tawabich Nagatu, who will be speaking to us today about the State Health Improvement Plan. Dr. Nagatu serves as the implementation manager for planning and performance at the Louisiana Department of Health. She received both her bachelor's and master's degrees from Louisiana State University and went on to receive her doctorate degree in public policy from Southern University. In her current role, she manages and contributes to a range of improvement projects associated with the organization's strategic plan and public health accreditation process. Additionally, she ensures the effective implementation of the State Health Improvement Plan, which is a collaborative plan involving community members and partners from across the state with a specific focus of improving health equity and community health. Tawabich is a lifelong resident of Louisiana and the proud mom of a 2-year-old boy. Dr. Tawabich Nagatu.
Thank you so much for that introduction and good afternoon, everyone. I'm Tawabich Nagatu, as mentioned, and I'm the implementation manager here at the Louisiana Department of Health. Today, I'll provide a brief overview of where we are with developing the State Health Improvement Plan. Next slide, please. Perfect. So for a bit of background, I just wanted to review what the State Health Assessment and State Health Improvement Plan were. The State Health Assessment, or the SHA, provides the foundation and data needed to improve the health in our state's population. It is a basis for setting health priorities, planning, and program development. It assists in coordinating state resources that will help to inform the SHIP. While the State Health Improvement Plan, or as mentioned, the SHIP, is our roadmap to a healthier state. The SHIP is not just a health department, but rather a health department plan, but rather a shared plan that describes what we collectively need to focus on as a state and how we can align ourselves and collaborate effectively to improve the health of all Louisianans. The purpose of the SHIP is to describe how the health department and the community it serves can work together to improve population health. We launched the Louisiana SHA dashboard in March 2021 on the My Sidewalk platform. To access that dashboard, you can simply go to www.louisianasha.com. There you will find data related to health inequities in Louisiana, as well as data visualization for each of the LDH's 9 regions. Similarly, this summer, we plan to launch a companion dashboard for the SHIP. And the SHIP's dashboard will have the capability to measure and track progress on shared goals and objectives. It'll increase accessibility to improvement projects and data, provide transparency for the public, and assist in quickly identifying focused priorities in various geographic areas of the state. Next slide, please. Seen here are our finalized SHIP priority areas listed in no particular order. They are behavioral health, chronic disease, community safety, and maternal and child health. We present these recognizing that they are very much interrelated. These priorities were intentionally broad by design so that specific goals and objectives could be identified by our community partners. For the current iteration of the SHA SHIP cycle, we were able to disseminate a statewide survey, as well as conduct one-on-one interviews with public health system leaders, community leaders, as well as conduct 2 regional meetings to publicly vet these priority areas. In total, we were able to capture roughly 6,000 Louisiana's residents' thoughts, experiences, and feedback on the areas they felt impacted their communities the most. Next slide, please. Currently, we are in the SHIP development phase. During this phase, we have been able to create SHIP work groups around each of the 4 priority areas you viewed on the previous screen. We conducted 33 public meetings via Zoom with our SHIP work group members, and were able to identify shared goals, measurable objectives, and potential strategies, as well as partners for each of the priority areas. Our goals and objectives were defined by our work group members, and these will be the ones that are tracked on our SHIP dashboard, so that measures on our progress can be tracked not just annually, but also quarterly and in real time. Once we finalize the SHIP plan, we'll reconvene our SHIP work group members in the summer, and after that, we will work towards launching the SHIP dashboard in late summer. Next slide, please. Lastly, we just wanted to share some of the attributes of what can contribute to effectively implementing a shared state health improvement plan. These attributes include having an explicit focus on primary prevention, ensuring that there's cross-sector collaboration, making sure that data is being shared widely and freely, as well as making sure that there's an intentional focus on elevating those with lived experiences. Who are closest to the inequities that we are working towards improving. Next slide. This is my contact information. Please, if you want to get involved with any of our work groups, feel free to email me, or you can email planningperformanceoph@la.gov. A special thank you to LHCC, as well as Jamie, who have been instrumental in helping develop this SHIP. If you want more information, feel free to just email me. Thank you so much.
Thank you, Dr. Nagatu. Next, we will have our keynote speaker, Dr. Ashley Winterstrom. Dr. Ashley Winterstrom is an associate professor at LSU Health Sciences Center, New Orleans, where she serves as director of the Louisiana Community Health Worker Institute and the Center for Healthcare Value and Equity. Dr. Winterstrom focuses on community health worker workforce development and policy, and she conducts community academic partnered research focused on promoting health equity and social determinants of health. Dr. Winterstrom.
All right, good afternoon, everyone. It's a wonderful opportunity to be here. Thank you so much for having me. Let's see, is it possible for me to share my screen?
Yes, you should be able to share now.
All right, fantastic. Give me just 1 second. All right, excellent. Well, again, my name is Ashley Winterstrom. I work at LSU Health in New Orleans. Thank you all so much for inviting me to be here today. I see lots of names of familiar friends and lots of faces, folks I've been lucky to work with over the years. So I hope I won't bore you to tears with things you've already heard me say many times before. But I was asked to talk a little bit about social determinants of health in Louisiana specifically. So it's an honor to be able to do that. So we'll go ahead and get started. I will say that in my professional life, most of the time I am doing teaching and training, which tends to be incredibly interactive. So I will encourage folks to please participate. I would love to hear from you all. There will be some occasions which I will ask for you to put some things in the chat. This will be a lot more fun and interesting if we have it be a little bit more of a discussion rather than just me talking at you. So please join in and interact. And feel free to put questions in the chat as well. So my goals for today are just to, for us by the end of the discussion to be able to list several social determinants of health, discuss the relationship between social determinants of health and policy, and then also describe some solutions to addressing adverse social determinants of health. I know that everyone's coming from a slightly different background. So again, I hope that everyone will participate and we can really think together about ways that we can work together to improve health in our state. So I know that obesity is a topic that many of us care a lot about and are interested in, and something that many folks are doing within their Healthy Communities coalitions. So I thought it would be interesting to start with a quick overview of the CDC obesity trend maps. And I am just curious, just show of hands, review in the chat or input in the chat, how many folks have seen these slides from the CDC before? It's going to be a map over time. Folks familiar with these? Yes. Seeing a couple hands. Okay, great. Might be familiar to some folks, for some it might be new, but in any case, we'll go ahead and go through these. Just know for those who may be new to seeing these, this is obviously a map of the United States. We are looking at percentages of folks in any given state who are overweight at this point. And we're going to notice some changes over time. We know that we're looking at body mass index here, which is not a singular perfect measure of health, but it is what it is. So we'll take it for what it is. But as you're seeing the data appear on the screen, just take a couple minutes to be thinking about what you notice happening here, what trends you see, and we'll talk about it at the end. So we start out here in 1985, quite some time ago, with data where many states hadn't yet started collecting data on obesity and overweight. And the states that had the sort of smallest percentage was less than 10% of people were obese. And then the states with a little bit larger number was a slightly darker blue color here, where it was 10 to 14% of people. So we'll go through in time and notice some differences. Within just a few years, we really start to see the map filling in with more data. And then in 1991, we see a bit of a change, which is that we have this new category here of 15 to 19% of people in the states are experiencing some obesity. So we could see here, unfortunately, that Louisiana is leading the way, along with our friends in Mississippi, as well as Michigan and West Virginia. So moving along to 1992, 93, 94, states are really filling in here. Up to 1996 here. And in 1997, we have yet another category, which is about 1 in 5 people, 20% are overweight or obese. And again, we're seeing Mississippi leading the way. We have Indiana and Kentucky as well. 1998, Louisiana joins those ranks, unfortunately. 1999, 2000, 2001, we have yet another new category, which is 1 in 4 people, or 25% or more. 2002, 2003, 2004, and 2005, we have yet another new category, 30% or more. 2006, 2007, 2008, 2009, 2010, filling in again. And then at this point, CDC slightly changed the way they collected data, so the numbers aren't directly comparable, but we have some more updated slides here. So we have maps from 2016 and then 2019, but we see a very similar trend with states with the highest percentage of folks who are obese by self-report at 35% or more, largely in the South here over in 2016, and then spreading a bit to the Midwest over by 2019. Okay, so now we have to ask ourselves a question: what happened? So for those who would like to unmute or are able to, please feel free to. And for those who would like to add something in the chat, what happened here? What do we think happened that we saw such a massive change over the course of this roughly 40-year period of time? Okay, iPhones, I see that. Thanks, Lori. Sure, so we've got more people engaging with their iPhones. I have mine sitting here next to me, certainly with other types of technology as well. Great, what else? What other changes do we see that have happened? Okay, more sedentary lifestyles. Thanks, Joy. I see lack of physical activity, high fructose corn syrup in products. All right, now it's coming in processed food, game system. Yeah, changes in food supply stamps. Worry. Okay, I feel like there's something more coming. Available fast food, larger portion sizes, less family time, more fast food. Okay, great. Eating prepared meals and eating out more, right? Oh, worry about safety. Sure, a lot more concern about personal safety out in the community. So people are staying inside more frequently, probably not letting their kids go out and play. Social media usages, people no longer growing food. Yeah, great point, Dr. Chalk. Certainly a lot of people used to do more local farming. Stress, screen time. Okay, great. Certainly data collection did improve. I see that. Fewer local markets, more Walmarts. Right, okay, fantastic. A lot of great ideas here. And thank you for sharing all of those. So let me, what do we have coming up here? COVID. Like someone's making a comment about COVID. Certainly COVID is, related, was exacerbated disparities around obesity. So that's great. So thank you everybody for chiming in. So next question I want to ask is, when we think about obesity as a problem, what do we usually tell people? What should they do to address their health if they are experiencing obesity? Workout. Okay, great. Thanks, Anna. Diet, lose weight, eat less, diet and exercise, right? Increase physical activity, eat healthy foods and exercise, push back from the table, right? It's the same thing. We can say it in a lot of different ways, but the idea is to be more physically active and to eat less, own their health, reduce stress, right? All of these things. So it's very interesting when we think about these social trends. What we just saw is a massive change over time, right? And when we ask the question of what happened, The answers that people came up with were really on a broad level when we're talking about greater availability of fast food, when we're talking about increased processed foods that's available in our diets, larger portion sizes. A lot of those are issues at a community and policy level. But it's interesting that when we think about addressing this very common health issue, which is obviously correlated with many other issues that we're very familiar with, including diabetes, hypertension, and lots of types of cancer, we still often have a very individualistic idea and approach to addressing the issue. And so the point of this discussion is to really be thinking about how, when we're trying to address these large public health problems, we can be thinking a little bit more about policy level issues and community level issues, because clearly all of our individual behaviors are shaped by the environment around us, sort of in the social ecological model, which I'm sure many folks are familiar with. All right, if there is any way to remove what is on the whiteboard, that would be helpful. I don't know if y'all can see that, but it looks like there were some additions put on there, which was great for the discussion, a little bit harder to see as we're looking at these slides. But in any case, so what we really want to think about a bit more today is social determinants of health and how all of these affect our health overall, not just related to obesity, but in general. So I'm sure that many folks are familiar that social determinants of health are conditions in the places where people live, learn, work, and play that really affect a wide range of health and quality of life risks and outcomes. So we're going to talk about these a little bit today. So I'll go through these briefly, and then we'll talk a little bit more about some specific examples in a few moments. So the first one I just want to touch on is economic stability being a huge one. Certainly employment. Thank you so much. That's much better. Employment being a huge one in terms of, can you put food on the table in the first place? We all probably know from going to the grocery store that unfortunately healthy food is oftentimes much more expensive than less healthy food. And so if we have a good job, we're certainly able to afford better food. Clearly our income is related to the areas that we live. It's related to the stress that we feel on a day-to-day basis. Also want to note issues about debt, and particularly medical bills. Our employment and economic stability obviously related to whether we have health insurance. Medical debt has gone way up in this country in the last several years. For a number of reasons, but certainly that affects our overall health. The neighborhood and physical environment, the quality of the housing in which we live is a tremendously important social determinant of health. We know that there are, well, we'll get into it in a minute, so I'll leave that for now, but housing quality is important. Transportation, safety, the quality of parks and playgrounds. A few folks mentioned in the chat, sort of this idea of leisure time physical activity. As we've seen changes in the availability of high quality parks and playgrounds, we've seen a decrease in leisure time physical activity. So people are just doing, less active things when they are away from work. Whether our communities are walkable. All of these things are important. Education, so certainly literacy, language, early childhood education, whether people have access to vocational training and higher education is important. There is a very clear correlation between life expectancy and formal education, so that we know that folks who are more formally educated actually live much longer than folks who are not. Food, certainly hunger, access to healthy options. Community and social context. So are people integrated into their societies? We know that in many communities where folks may be isolated for a number of reasons, either because they are living far away, they're in rural areas. Certainly some communities are isolated because they may have limited English proficiency. They may be undocumented. There's a lot of reasons that folks may not be well integrated into the society. Whether people have support systems, whether they're engaged in community. Discrimination certainly is a huge one. Stress. And then one that I think gets left out a lot, but is very important, is incarceration. And I will talk a bit about that more towards the end of the presentation today. But it's important to recall that Louisiana, unfortunately, leads the nation in rates of incarceration. And we know that people have very limited access to appropriate healthcare services while they're incarcerated. But incarceration is not just related to the health of people who are actually, behind walls or behind bars, but rather entire families and communities that have loved ones who are incarcerated are affected for a number of reasons, and there are documented health outcomes that are adverse for children of people who have incarcerated family members. And then finally, we get to healthcare, so health coverage, availability of providers. This is a really big one, especially when we are thinking about populations that are Medicaid members. There are many providers who do not take Medicaid due to lower reimbursement rates, which can certainly prevent people from getting services in a timely manner or at all. And then, of course, linguistic and cultural competency of healthcare providers, and then the quality of care. So these are really all things that are determining our health. Probably very familiar to many folks on this call. So it's important to be thinking about social determinants of health on an individual level. So we have our little generic person here, but the idea behind this is to really think about how much of one's overall health is made up by these social determinants, these sort of outside factors that are not directly related to things like our genes or what what we often think of initially when we think of what determines our health. So about 50% of health overall can be traced back to zip code. So that's directly related to things like our physical environment, whether we're safe in our communities, job status, education, all of that. About 30% is health behaviors. So that's things like tobacco use, diet and exercise, alcohol use, risky sexual activity. And then finally, roughly 20% is attributable to healthcare access and quality. I always like to emphasize this where I work. I teach medical students as well as public health students. And I think it's important for future health professionals to understand that even when they do a fantastic job of providing high quality healthcare, that's never going to be sufficient to really address some of our larger public health problems and certainly disparities that we see today. I will note, I know that as we're thinking about social determinants of health on an individual level, what I hear in my work on a very regular basis is this notion of addressing social determinants of health by connecting people to services for some of these issues. So for example, if somebody is struggling with food security, we can think about that being a social determinant of health and make a referral to a food bank. That's fantastic. We can think about helping people improve their diet and exercise. Maybe we're going to make a referral to a smoking cessation program. Again, that's all fantastic and really, really great. I'm excited throughout my career in public health to see that there's more and more emphasis on social determinants of health. We're seeing more and more screenings happen for social determinants of health, particularly within public health units throughout the state. I'm lucky to work with a lot of community health workers who are doing these screenings. And I know that a lot of the Medicaid managed care organizations are also really emphasizing doing social determinants of health screenings and making referrals for services. So that's wonderful to see. However, it's really critical to understand that that is only a piece of thinking about social determinants of health and addressing social determinants. Because if we think about them only on an individual level or how we can address them on an individual level, we're always going to be a little bit behind because we're going to be really taking sort of a downstream approach to addressing social determinants, waiting until somebody has a lack, something is missing, and then trying to connect them to a resource. So what I really want to emphasize today is a much broader approach to thinking about social determinants, which is to think about how they are related to community and policy, and how we can address social determinants at those levels. So going back to our ecological model with the concentric circles that we saw a couple minutes ago, how can we be developing interventions? How can we be changing the conditions that really affect our health overall? So the slide that I have next here is a map of New Orleans. And I realize there are lots of folks here today from all around the state. So forgive me for being New Orleans centric. This just happens to be a great map to illustrate this, but we see things that are similar throughout the state and throughout the country. But what you're seeing here again is this map, and the numbered in the circles are life expectancy. I've had several folks I've shown this to recently, and they always ask the same question, which is, when are these data from? These are about 10 years old. So this is pre-COVID. Things have changed. However, the trends hold. So this is life expectancy based on neighborhood. So what we can see here is that in some of our neighborhoods over here, which are, sort of the Lakeview sort of area in New Orleans, life expectancy is about 80 years. And then we get down into the Iberville area as another example, and life expectancy is about 55 years. And then some other areas of town, we see anything from 66 to 75. So a pretty broad range. I am just curious, and feel free to throw this on the chat or unmute. What are your thoughts when you see these numbers for life expectancy in a major American city today?
Oh, my feelings as a social worker. I say feelings first, but it's really sad. And I think it really illustrates the point you're making just in terms of all of the systems that are at play well beyond an individual level. These zip codes are made of individuals, but certainly each individual is not creating this issue because they don't eat right, or because they aren't exercising, or even because they don't have access to the food. That this illustrates to me the systemic issues that you are speaking about.
Great. Thank you so much for sharing, Cassandra. I appreciate that. Yeah, I'm seeing in the chat, very sad for our modern times. 50% can be traced back to zip code, inequities in health. Thank you, Joy. And nice to see you, Joy. I'm glad you're here. Very shocking. Yeah, I will say, when I first saw this map, I was horrified, and I've seen it 100 times since then, and I'm still horrified. There are days when I don't want to go to work because I'm tired and whatever else, but this is what gets me out of bed, because when I see this, it is horrifying, and I cry every time I talk about it. So forgive me, but I really believe we can do better. And when we see, see these numbers, it's saddening in and of itself. But then when we stop and layer on top the very obvious issue, which is race. These neighborhoods are essentially segregated by race. We're seeing massive differences in life expectancy based on racism, and that is not acceptable. So we know we have work to do. And so that's what we're going to continue to focus on just a little bit more today.
Well, I have something to say. It doesn't make me feel well, because I live in that area that's 66 years. Is it 66 years? Well, that only gives me 5 years left to do the work that I have to do.
I couldn't see who was speaking, but thank you for.
This is Angela Chalk.
Hi, Angela.
Yeah.
Glad you're here. Good to see you.
Yeah.
And thanks for sharing.
Yeah.
And me too. I live in St. Roch, so yeah, all right, I got to get to work here, right? No, it's very, very disturbing. And keep in mind, this is overall, this does not necessarily mean that any of us are destined to a particular thing, right? But these are population numbers. But we know we have massive inequity here. I know that we're going to have several other speakers later on today who are going to talk a little bit more about some of these policy issues related to social determinants of health, but I wanted to highlight just a few that are relevant in Louisiana and in New Orleans today. So one is housing policy. What we're seeing here is a red line map. I'm sure that many folks are familiar with redlining, but for those who may not be, or could just use a little refresher, I'll just give a very, very simple overview. I'm seeing something in the chat, yeah, based on centuries of inequitable systems, absolutely. So in any case, we have a history in this country of redlining. Very overly simplistic version is that there, 40, 50, 60, 70 years ago, it was very clear that the banks were in cahoots with the federal government. Basically, banks would take maps of any given community, literally draw red lines around various areas and decide which ones they would rank from least desirable to most desirable. basically would not issue federally backed mortgages to people of color to live in the more desirable areas, which helped contribute to neighborhood segregation. Again, way oversimplification of what happened, but really led to a concentration of people of color living in certain areas and greater availability of housing to people who are white at the same time. So helped sort of solidify neighborhood segregation. At the same time, after World War II, there was a massive housing shortage in this country, and the federal government engaged in a few other activities that helped to promote neighborhood segregation. One was that they encouraged home ownership among people who were white by building new communities and offering them for sale at a relatively low price, and available only for folks who are white, and then also at the same time developed public housing. And it was initially segregated, and the idea was that there would be housing for people of color and housing for people who are white. But as a general rule, people who were white had a much easier time accessing home ownership. So they bought houses. And then there was, there ended up being a waiting list in many cities for public housing. And so they eventually opened it up to people of color. So led to a concentration of people of color in public housing. So it's problematic in terms of segregation in and of itself. But when we think about what the federal government did to promote home ownership only for white people, they inherently put people of color at a huge disadvantage, because we know that home ownership is the most effective way to transfer intergenerational wealth. So it's led to more intergenerational wealth for people who are white and more poverty for people of color. So housing policy has been inherently racist. And I will say, if you want to, everything I'm sharing here is just, very quick overview, oversimplification. If you'd like to read an excellent book about this, I highly recommend Richard Rothstein's The Color of Law. It's an excellent book, very, very well researched. So just a little bit about housing policy. And then this is a more recent statistic that I just want, or a map, obviously, with statistics, as I just wanted to share today. So this is our state of Louisiana, and it's showing percentage of renters who are burdened. Burdened is defined by having more than 30% of one's income being allocated just to rent. So you could see the various areas and see where we have 50% or more of renters being burdened. So again, thinking about the history of our housing policy, how that has continued to disadvantage particularly communities of color, and certainly many rural communities as well. So I'm sure y'all can recognize your own communities in there and see where a lot of renters are being overburdened by expensive rents, compared to their income. So housing policy is a big issue. Also wanted to highlight a little bit about transportation policy. I'm just curious, can anyone recognize what these photos are? Feel free to throw it in the chat.
Claiborne Bridge.
You bet, that's right. Again, this is going to be an oversimplification, but we want to think about transportation policy and how that affects our health in this country. So when the U.S. highway system was being finished, one of the last areas to be completed was in Louisiana, and they were making a decision about where to put I-10. And as I understand it, the initial proposal was that it was going to be placed sort of near the French Quarter along the Mississippi River. That would be a very logical place to put that in terms of transportation and, transportation of goods, if we're thinking about all the goods that are being, brought in all the time on the Mississippi River. But residents of the French Quarter said, oh, thanks to whoever put the color of law in the chat, appreciate that. In any case, the residents of the French Quarter opposed it strongly, and they used a term that I'm sure many of us are familiar with, NIMBY, not in my backyard. They didn't want to have a highway running through that area. And so, folks called their local politicians and they called their friends, and eventually were able to raise enough awareness about why they didn't want this, that a new proposal was put into place and finally executed, which was that the freeway would be placed right over Claiborne Avenue. And so that's what we see today is the I-10 over Claiborne. But what we see over here on the right is what Claiborne Avenue used to look like. Beautiful grassy, neutral ground, lots of gorgeous oak trees where families would come out every day on the weekends, relax, hang out, have community events, really beautiful area. And to be clear, this was a predominantly African-American middle-class neighborhood through the Treme. And so once the Claiborne Bridge was put into place, it decimated property values. Many people had to leave. A lot of the businesses left, and just had a tremendous effect on the community in terms of economics. And then also, if we want to think about pollution, certainly we've got cars driving by there every day. So noise pollution, and then air pollution, obviously. So that's just one example of how transportation policy can be a social determinant of health in the way that it affects communities overall, the physical infrastructure of communities. And this is merely one example. This is New Orleans, right? But we see similar patterns throughout the country where freeways are often, on-ramps, off-ramps are placed in areas that are predominantly communities of color, and then it has a detrimental effect there. So I'll just say one last thing on this little slide, which is to just note that the community that lived in this area painted oak trees on the pillars of the bridge. I'm sure many of you are familiar with this, but for those who haven't ever seen this, in order to remind themselves and remind the public of what this area used to look like. So I wanted to share that as one. I'm seeing a few things in the chat about gentrification. That is absolutely true. Huge tough fight to keep highway from going across the historic French Quarter. Yeah, thank you, Randy, for sharing that more information there. So feel free to read more about that. So transportation policy is another issue. So these are just a couple of major issues. I think everyone is familiar with this. This is hitting home to a lot of folks. But the main thing that I want everybody to get out of this is that when we're thinking about social determinants of health, we are thinking about policy. These are not individual level things. These are policy level things at the community level, and then even at the broader state and federal level. So one solution is community level advocacy. And I can't emphasize this enough, how much power we actually have as citizens when we come together and when we get creative about the way we want to address issues. So I'm going to give you just a couple examples that I think are important. One is there was a group of, it was a community coalition that involved a lot of community health workers who were working together in Southern California several years ago. And they noticed an interesting phenomenon, which is that it seemed like a lot of their elementary school kids were being hospitalized for asthma. And so naturally they were concerned and wanted to try to figure out what was going on and what they could do about it. And they were smart and made the very simple observation that the elementary school was literally across the street from a truck driving school. And they said, okay, we think we know what's happening here. How can we show that there is a relationship between the truck driving school operating and our kids going to the hospital for asthma? So they decided to gather some data. So they partnered with a university and did a couple of things. So one is they collected air samples at various times of day so that they could show that the content of particulate matter in the air was different based on whether the truck driving school was operating or not. And not surprised that they found that there was a higher percentage of particulate matter in the air when the truck driving school was operating and all these diesel trucks were running. They also partnered with the local hospital to document when children were being hospitalized for asthma. So they were able to access some of those records. And then they put those data sets together and were very clearly able to demonstrate the correlation between when the truck driving school was operating and when children were being hospitalized for asthma. And so they brought that information to the local city council and they advocated successfully for a change in zoning laws. So the truck driving school had to be relocated. Really a simple example, but I think very profound. That could have gone on for who knows how long if that community coalition hadn't come together and said, hey, we see what the problem is here. Let's figure out a way to document it, produce our evidence, and advocate for a change. And they were successful. Another simple example, and I'm sure that many folks have worked on campaigns like this, but I'm familiar with a group of community health workers who are working on the US-Mexico border several years ago, back in the early 2000s, and living in a community with a very high prevalence of diabetes. And again, they were smart. They realized what was going on. They said, gosh, we really don't have good access to walking spaces or physical activity spaces here, or fresh, healthy food. And so they did a couple of things. One is they approached the local grocery store owner. There was really just one main grocery store in the community, and talked to that person about changing the types of food that were carried there. And so they were able to convince the grocery store owner to start carrying healthier food. So, lower fat milk, wheat bread, just, healthier stuff that folks would want to buy. And also worked with the grocery store to change the way they displayed their food. So previously, when you would walk in, you'd see large displays of cold drinks and candy and chips and all the delicious things that people like to buy. And instead, they moved the display of fresh fruits and vegetables right up front. So that would be the first thing that people would see and be more likely to buy when they came in. So they did that. And then they also got together and they wrote a grant together and got some community development block grant funds in order to place a walking trail in their community. And then after that, started doing walking groups and health education to really support the entire community. So again, very, very simple idea, but just illustrating the point that when we get together, we can work together to change the laws in our communities and the physical infrastructure of our community. So I know a lot of what I've talked about has been, less than happy and exciting, but the point is that we really can make a difference when we come up with creative, community-based solutions, and really think about what is important to us. So really can't emphasize enough the importance of community advocacy and getting laws changed as needed. And then finally, this slide looks like a little bit of a non sequitur, but I will explain why I put this one in, which is that we want to remember our political power. We can vote. We can be engaged in the political process. The Louisiana legislature is in session right now. They are considering all kinds of bills about education, about healthcare, about what will be covered by Medicaid. We can all participate in these processes. I think that sometimes I work for the state, many of us work for the state, and it can be a little bit scary to say, well, but wait, I actually can't do anything because I'm a state employee. We certainly can participate in the political process. First, we can do lots of things as individual private citizens. We can vote the way we want to. We can contact our legislators using our personal emails. We can make phone calls on our personal time. So if there are things that are important to you, by all means, do that. But then also keep in mind that depending on which agency you work at, you may be able to engage in the legislative process a little bit more directly by providing information to legislators. So if there's a particular topic that you have knowledge in, that you are excited about and passionate about, don't count yourself out from participating in that. Talk with the folks you work with, get good advice on what the sort of guardrails about how you can participate, might be. But there's oftentimes more we can do than we think we can, especially when we collaborate with other agencies. There's also, I think, a very common misconception that nonprofit organizations can't do any advocacy at all. And that's not actually true. Nonprofits are able to do a limited amount of advocacy. So if you're in the situation where you work at a nonprofit, talk to your colleagues about that and find out what the rules are. And then also, I'll just going back a bit, I'll just specifically mention, sometimes there are misconceptions about education versus advocacy. So certainly we can't do advocacy on company time when we work for the state. We can't tell lawmakers how to vote. But we can do education. So, don't shy away. Again, talk to your bosses, your colleagues, and figure out what the parameters are. But there's oftentimes more that we can do than we think, particularly those of us, we're working in public health, we have knowledge. It's okay to share that under certain circumstances with legislators. So don't shy away. Finally, I've shared this slide. I'm saying that we should be engaged in the political process. One thing I want to point out, I mentioned this briefly earlier, is that Louisiana has an incredibly high rate of incarceration, and some of our population is disenfranchised due to felony convictions. Our rules in Louisiana changed a few years ago based on advocacy by community groups who were able to change laws. Such that it used to be people who had a felony conviction could never vote in the state of Louisiana. Again, that is no longer the case. I believe it is folks who have been off probation or parole for at least 5 years are able to vote again, as long as they register, and they may have to jump through some hoops. They shouldn't have to, but they may have to. But just want folks to be aware of that, because this is a common misconception that if you have a felony conviction, you can never vote again. It's not the case. So if you know folks in that situation, let them know they can have their voting rights restored. And I also want to bring this up again and just explicitly talk about the relationship between race and incarceration in Louisiana. We know that there is a high rate of incarceration, that people of color are disproportionately incarcerated. We also know that, Angola, as our largest prison in the state, is literally a former slave plantation. So felony disenfranchisement has basically been a continuation of slavery. For folks who are interested in learning more about this, I know many people are already familiar, so I'm preaching to the choir, but Michelle Alexander wrote an excellent book, probably 10 plus years ago at this point, called The New Jim Crow: Mass Incarceration in the Era of Colorblindness, I think is the tag. Read it. It's fascinating. It's horrifying, but it's important for us all to understand how the legacy of slavery, disenfranchisement, Jim Crow has really continued today within our system of mass incarceration. The better we know about it, the better we can talk about it, the better we can educate ourselves, and the better we can advocate for the changes that we would like to see, whatever those may be. So I think that is it. I can go on all day, but I know y'all probably have questions, probably have things that we want to talk about, and certainly there are other great speakers. So I will hush and open things up for questions.
Wow, that was fantastic. Thank you so much, Dr. Winterstrom. If you have any questions for Dr. Winterstrom, please use the chat or Q&A function. That was absolutely incredible. I think we learned so much. As we wait for chat, I do have wait for questions to come through the chat. I guess my question to you would be, how do we empower communities to know that they even have the voice to make the change? Because a lot of communities, some don't even know what they're up against. Some don't know what's happened. Some don't know the history, and some just, like I said, don't know they have a voice. How do we empower those communities to come together and just work towards policy change to make those changes in their communities?
Wow, I think that's a really good question. I don't have a single easy answer. I mean, I think first and foremost is getting people together, right? So community forums, right? Let's bring people together. Let's talk about what's going on. I think it's very powerful to have people do exercises like community mapping, and literally can bring together 20 people in a community forum and say, hey, let's draw a map of our community. And what tends to come out when I've done exercises like that is the first thing you see is there are resources in your community. A lot of times there are more resources than people initially identify, than one would initially think of. But everything from the individual who's got the barbershop out of their house, or the person who's got a talent and whatever. Bring people together, find out what is going on in their community and what their assets and resources are. That's key. Really, really critical to always be focusing on what the strengths are. And then identify, what are the challenges that you're facing? What are the health problems or what are the social problems you're facing? And then, through dialogue, gee, guys, what do you think is causing this? What do y'all think is the root of this problem? People are smart. People have experience. And then start strategizing about how can we work together? Who do you know that has connections here, connections there, what other organizations can we bring in? But I think it's, it takes time, it doesn't happen overnight. But I think just, really getting people to realize how they can draw on their strengths to address, problems that they see. And then, certainly, bring in outside experts as needed to talk about the policy process, where they can engage, talk about history. I've open it up to other folks who have ideas too. Again, I'm just one person trying to come up with an answer to a really complicated question. I'm sure other folks have thoughts too.
Thank you. There is one question so far. It says, since economic development and education are the key determinants, it will depend on resource allocated at the state level. That requires political will at the state level. How do you motivate those individuals?
Again, I, could say, talking to policymakers about what's important, what the priorities of the communities are. I think it's about, building power and getting people in any given community together to have the same ask, keeping in mind that legislators do work for us. They at least theoretically should be responsible to their constituents. So when several members of a constituency approach a legislator and say, hey, I would like to see X, Y, or Z, I think we can start to move the needle. And I don't mean to suggest that any of this is easy, but I think that we have, more power than we sometimes realize we do.
Okay, there is an additional comment to that. It says, policymakers are not ignorant of the issues, they may not care. Which is true. So I'm gonna let you answer that.
I don't have an easy answer. I think there's a lot about figuring out what their priorities are. I recommend there is an excellent website called projectvotesmart.org, where you can look up literally every elected official in the United States by your address. So you can just put in your address and it'll tell you everybody who represents you. And there's a lot of great information about where they've gone to school, what organizations they are members of, who their families are, what their voting records are, who donates to their campaigns, what their public stances on issues are. And this is for people who are currently elected as well as for people who are running. So I recommend using that and trying to figure out, who it is that represents you and what their agenda and issues might be, what their priorities are. And then I also would think, really carefully about, how can I say this? What your message is that you might be taking to a policymaker and who's the best person to deliver that message to a policymaker. And then, we've also got to think strategically about, how can you engage several different policymakers? How can you engage them, around the same issue? How can you set things up? Again, it doesn't always happen overnight, and I will never pretend that it does, but I do think change is possible.
Yes, there's one great comment. I'm sorry. Yeah. Let me see if I can catch that comment in the chat. It says legislators are hearing from lobbyists daily, if I can hang on to it. And if their constituents are not communicating, they hear from lobbyists daily, and if the constituents are not communicating, they're more likely to side with those special interest groups. And that is so true, that we do have to take it upon ourselves to communicate with those that we do elect. And I think a lot of people don't realize or forget the fact that there are lobbyists at the state capitol and other places who are lobbying for their interests against the interests of community. So that's another avenue that people really need to be aware of. Do we have any other questions? I think we have one. Let me see. It says the American Public Health Association grades our legislators and they uniformly fail on votes related to social justice and very few exceptions. So it's more of a comment rather than a question. I don't know if you wanted to comment on that or not. But.
Do you mind reading again the American Public Health Association
Yes, it says the American Public Health Association grades our legislators and they uniformly fail on votes related to social justice with very few exceptions.
Gotcha. Gotcha. Yeah, again, I don't have any easy answers, and I appreciate, other thoughts on this.
Are there any other questions, Jamie? Is there anything I'm missing in the chat? Okay,
If there's a question in the chat from Joy that I say, instead of giving voice to the voiceless, we need to focus on giving ears to the earless. How can we better connect those and those empower to make change? So that's how can we better connect to those empowered to make change? And it's kind of the same thing that you really talked about. Yes.
Yeah, I love that idea of giving ears to the earless. That's beautiful. I will use that.
Yeah, there is another question in the chat. It says, I noticed there was no discussion of the oil and gas industry and how that has impacted health. It seems that people are afraid to take on that giant.
Yeah, that's a great point. I honestly don't have a lot of expertise in that area. There's a lot more that we could have talked about today. Just really use a few examples, but certainly it's an important area to explore. So I would encourage folks. No.
Jamie, do you see anything else in the chat?
I do not.
Okay, well, seeing none, speak now or forever hold your peace. We have a few minutes before we release Dr. Winterstrom back to her day.
Well,
Okay,
thank you all again.
Yeah.
Thanks for the opportunity to be here. Please call me Ashley. I don't any fancy titles. My email's on there. If y'all want to collaborate on something, if I could be helpful in any way, you know where to find me. I'd love to hear from you all. And again, great to see lots of colleagues and friends here today. Thank you.
Thank you so much. This has been a fantastic presentation. There's tons of accolades in the comments if you want to take a look, but this has been incredibly eye-opening and fascinating, and we thank you for your time.
Sure.
Okay. That was such a great talk by Dr. Winterstrom. I think she's given us quite a bit to think about and pinpointing a lot of work that we have to do as a community. But we will move along to our next portion of the summit. I now invite you to watch LHCC in action, which focuses on the LHCC community grants.
The Louisiana Healthy Communities Coalition's LHCC provides small community grants to groups all over the state fighting tobacco and obesity via policy, systems, and environmental change. Policy, systems, and environmental changes, known as PSC, are proven long-term sustainable improvements, and we let communities choose for themselves how they want to spend their grant. LHCC funds school, church, and other nonprofit community-led gardens, creating environmental changes that fight obesity to provide healthy eats for a range of citizens, from students to cancer patients. In parts of Louisiana affected by high obesity rates and poverty, LHCC has made a significant impact. In Sicily Island, in Northeast Louisiana, the nearest grocery store with fresh produce is 17 miles away. LHCC helped the First Baptist Outreach Ministries repurpose an unused lot into a fruit and vegetable garden, providing healthy produce to the community. At West St. John High, teachers and students have built a community teaching garden, hosting a monthly fruit and vegetable market. In Lafourche and Terrebonne parishes, the St. Francis Vegetable Garden people have been distributing fresh produce for years, with volunteers planting more than 100 citrus trees in public spaces. Residents can now pick fresh fruit for free, with the remaining produce going to local food pantries. LHCC, leveraging work done by the Louisiana Ag Center and Louisiana Central have helped create both systems and environmental change in the Oberlin and Alexandria farmers markets, with, for example, SNAP beneficiaries now being able to shop there. When COVID-19 broke out, many workers lost their jobs, supply chains were disrupted, and suddenly people couldn't get food. LHCC jumped in and took up the challenge, making sure the community had access to healthy foods. LHCC funded Sprout efforts to deliver vegetable plants to elderly residents of color in New Orleans. Healthy produce was delivered and COVID-19 was kept at bay. Using LHCC funds, Market Umbrella, Crescent City Farmers Market, and the Hammond Farmers Market developed online ordering and contactless delivery of fresh, local produce, benefiting everyone from food producers to people below the poverty line. LHCC funded the Cancer Association of Greater New Orleans, or CAGNO, to deliver contactless nutritious meals to cancer patients, while the United Way of Iberia set up many food pantries, allowing neighbors to help neighbors. LHCC also supported and funded physical activity through environmental change. In DeRidder, personal trainers demonstrated how to use park exercise equipment, and now there's signage to explain the same. In Toulouse, the walking trails were repaired. In Gina and Urania, the introduction of park benches and picnic tables inspired both physical and economic improvements downtown. While in Ola, building on its already strong farmers market, funds were used to enhance the outdoor educational public space so people could benefit from classes on everything from diabetes to stress management. In Baton Rouge, LHCC funded Front Yard Bikes, a place where disadvantaged youths learned bike repair, earned a bike of their own, and provide others with much-needed transportation. That work became even more critical when COVID-19 hit, as bikes provide an affordable, contactless way to travel. LHCC is an active supporter of Complete Streets ordinances, which requires new infrastructure to take into account all modes of transportation: walking, cycling, public transportation, etc., not just cars. In New Orleans, Hammond, and Lake Charles, LHCC has funded Better Block events where a certain space is marked off with crosswalks, bike lanes, and other transportation aids to spur Complete Streets ordinances. Lake Charles has also used LHCC funds to boost their physical activities, adding trail signs, park benches, and water bottle stations. LHCC continues to help communities in healthy ways, big and small, such as fighting tobacco in Shreveport by helping it go smoke-free, supplying smoke-free signs to Rapides Parish schools, and helping people eat and move in healthier ways, even in a crisis. LHCC's mission is to build healthy, thriving communities by mobilizing them to develop and implement policy, systems, and environmental changes and fight tobacco and obesity. We do that by providing state leadership and resources, communications, an annual summit where people learn, share, and get inspired, and last but not least, small grants for groups to create the change in their community they want to see. Join us. To learn more, go to healthylouisiana.org.
Thank you so much for sharing that video. Again, I put it in the chat, but the voice of those two videos we've shown are Jamila Freitman, who is one of our panelists and one of our members, active members of the Louisiana Healthy Communities Coalition. So some of you do recognize her voice. So I just wanted to give her credit. Thank you, Jamila. Now we are down to our panel section, and we have our moderator. I will introduce Dr. Earl Benjamin Robinson. Dr. Earl Nupcius Benjamin Robinson leads Louisiana Public Health Institute's Tobacco Prevention and Control and the Louisiana Campaign for Tobacco-Free Living. Prior to this, he developed and served as director of the Louisiana Department of Health First Equity Office, Office of Community Partnerships and Health Equity, and led the development of LDH's first agency-wide health equity plan. Dr. Benjamin Robinson is also faculty at Xavier University's Public Health Science program and has been an adjunct associate professor at Tulane University School of Public Health. Dr. Benjamin Robinson's entire bio will be available after the conference. I introduce you to Dr. Earl Noopsius Benjamin Robinson.
Thank you, Jamie. And everyone, you can just call me Noopsius. It was a pleasure to see Ashley come on speak before I started the session. She's always wonderful to listen to and a very passionate public health practitioner. So I'm always learning new things that she's doing, but also it's just refreshing to hear her share her perspective about health, and particularly as it relates to social justice. So that was a very good session. Thank you guys. Again, thank you, Jamie, for that introduction. As she stated, I am Earl Noopsius Benjamin Robinson. I am the director of Louisiana Public Health Institute's Tobacco Prevention and Control Division, and also the director of the Louisiana Campaign for Tobacco-Free Living, and the newly appointed of the new office at the Louisiana Cancer Research Center, the director of the Office of Community Outreach and Engagement. And so I'm very excited to be here today to share, to moderate a conversation that is centered around what those social determinants of health, and by social determinants of health, we're talking about those social and economic factors that contribute to health outcome inside our community. So I'm glad to be moderating a conversation today where individuals who are working in each of those areas will be speaking and sharing information with us to help build our awareness around these factors, so that we can lead this conversation understanding what it is that we could possibly do as it relates to the economy, as it relates to education, as it relates to neighborhoods and built environments, or social and community efforts, and then also healthcare. We want to leave the conversation having an understanding of how each of these social determinants has a part to play in the health that you see inside your community, and what it is that you can do, that you can glean from these conversations to take back into your community. So glad to be moderating this conversation today. So I'm happy to introduce to you the individuals who will be speaking about the social determinants of health. Again, these are conditions in the environments where people are born, they live, they learn, they work, they play, they worship, and they age. And as I stated earlier, these are things that affect a person's quality of life, the risk behaviors that they might be participating in, and their overall health. And so, as I stated earlier, also, we're going to be having speakers from each of these sections inside our sectors inside social determinants of health, to speak to what's happening, how these sectors relate to the health outcomes that we see happening. And so, without further ado, how this is going to go is I'm going to do an introduction for each of the panelists, provide you their name, give a brief bio, and then they will have about 8 minutes to share information with us, given today's topic. And then we're going to go from one panelist to the next, and each one will be given, I will do a bio, and then they have 8 minutes to provide information to you. Once that is complete, what I will do is we will open the floor for questions. I have some questions already that I could possibly ask the panelists, but we're also going to be really particularly looking at what are the questions that are coming out of the chat. So without further ado, our first subject matter expert that will be talking about economic stability is Melanie Henderson. She is a native of Baton Rouge and a proud LSU graduate with a passion for giving back to the community and supporting local nonprofits. She is a strategic collaborator with experience in public relations, communications, project grant management, and disaster assistance. As Director of Community Impact at Community Capital Area United Way, Melanie plays a cross-functional role on the resource development and community impact team. Without further ado, I welcome to you, Ms. Henderson. Thank you for joining us today, Ms. Henderson.
Hi, good afternoon. Thank you so much for having me. So I am from Capital Area United Way, and at our organization, we work to leverage partnerships in our community to advance the common good through education, income stability, and healthy living. And about 10 years ago, Capital Area United Way started participating in a study with United Way Worldwide. And that study provided a framework, language, and tools to measure and understand the struggles of a population called ALICE. This is an acronym that we are using in all of our presentations and our outreach. And this is an acronym for the population of asset limited, income constrained, and employed. So if you have not heard of ALICE, I think you might start hearing about it now that you know after it's been named. So these are really the households with income above the federal poverty level, but below the basic cost of living. And in order to provide a better understanding of ALICE, United Ways throughout Louisiana have been sharing these findings with different groups. The data that we do have on ALICE is pre-pandemic, but the new report will be coming out in May. There was a study done right after the pandemic, so I'll be able to talk about that a little bit, but please check back at the end of May for the most up-to-date data on ALICE. But the current report reveals that 33% of Louisiana households are considered ALICE. Another 18% live in poverty. So together, 51% of Louisiana's households cannot afford the basic expenses. And this is the housing, childcare, food, transportation, and healthcare. ALICE represents a growing number of households in our communities that just cannot afford these basic necessities. The research that is provided, it allows for meaningful conversations and discussions. We're able to attract new partners and ultimately inform strategies for positive change. The data also provides tools that explain the persistent level of hardships faced by the ALICE population. It also reveals aspects of the Louisiana economy that's not typically tracked by traditional economic measures. So the ALICE report really highlights 3 critical trends, and it's that the cost of living is increasing for these ALICE households. Worker vulnerability is increasing while wages stay stagnant, and the number of ALICE households is increasing in Louisiana as a result of rising costs and stagnant wages. So this matters to individual families, but it also matters to Louisiana as a whole. It impacts the whole community. A small drop in wages or hours or an unexpected emergency really could destabilize a large group of households. And then on the other side, a small increase in wages or a decrease in rent could help push families above that threshold. So we are really fighting for these that are just stuck in that cycle. And whenever COVID-19 hit, just over 576,000 Louisiana households were already that one emergency away or a financial crisis from stepping into being an ALICE population. But this really set the stage for the unprecedented economic impact of COVID-19. The ALICE study specific to COVID found that households below the ALICE threshold were more vulnerable they hit harder financial issues and with the economic slowdown. And then ALICE households, they need more help in navigating the income interruptions. 17% of the respondents said that they called 211 to help locate basic needs and ask questions about COVID-19. And so all of this data that we gather allows for action, and it's also used to generate solutions to these problems that ALICE households have. We also use this report to create equity across communities. The measures of cost of living, financial hardships, and changes in the labor force presented in the report helps stakeholders ask the right questions, and we can make data-driven decisions. The data can also help policymakers and community organizations identify gaps in community resources, and it guides businesses in finding additional ways to assist their workforce and increase productivity. And so this is both in times of economic growth and in times of economic recovery. We all know that having money saves money. Having income means that households can build their credit scores, they can avoid late fees, predatory lending, and high interest rates. In turn, that means that ALICE families have more resources to use to reduce risks, like having insurance, staying healthy, the preventative health, or saving for an education. And instead of being in a downward cycle of accumulating these fees and debt, families can move into the upward cycle of saving and have their health be in a better position to be able to be engaged in their communities and enjoy a quality of life. This also leads to greater economic activities for our communities, greater tax revenue, lower level of crimes, and fewer demands on the safety nets. We're able to invest more in infrastructure, schools, and healthcare. And we know that the return on investment in strengthening the ALICE population is strengthening the whole community. You can download the report. The website is www.launitedway.org/ALICE, and I will drop that link in the chat. Like I said, I do invite you to come back in at the end of May and see how the findings have changed. But we definitely at United Way and a lot of other funders rely on this data to know what we need to do in order to really continue transforming our community and taking it to the next level.
Thank you so much. Thank you so much, Melanie. It's really disheartening to hear that. I believe you indicated that there was, what, 51% of individuals can't afford basic necessities.
Yes.
This really speaks, it's one thing to think that you know that, but to have someone like yourself working in this area and you have that data in front of you, and this event today, we get to hear that, that's powerful, because what we can do is take that back to the community and share that information with the stakeholders who exist inside the community, but also with representatives to let them know that things are needed to help stabilize the economy and to make certain that people have what they need to be healthy and well, and also talk about the connection between the economy and its stability and health. So thank you so much.
Absolutely. I encourage y'all to look at the website where the ALICE report is, because it's interactive and it's broken down by parish, region, so you really can get an overall or just zone in on one area.
Thank you so much.
Thank you.
And so next, we're going to talk about a social determinant of health in the area of education, access, and quality. And Dr. Allison L. Swift is going to be the person who will be leading this topic, focused on this topic. Dr. Smith is a project director of NOLA Cares at Beloved Communities. She brings with her 20 years of experience working with children and families. Dr. Swift is a former early child educator and administrator, an independent educational professional development facilitator, 0 to 3 National Center of Infants, Toddlers, and Family. She works with them and is one of the leaders of the 21st Century Fellow. And so without further ado, we're going to go ahead and have Dr. Swift come and talk to us for about 8 minutes on the topic of education access and quality.
Hi, thank you so much. I am really excited actually that I got to go right after Melanie Henderson, because I can, with what I'm going to communicate with you today, we can actually give some real faces and add some numbers to some of the things that she was bringing up in terms of who are these ALICE people. So today I'm going to really focus on early childhood education. As we know, it is the foundation
of all other, education. That's the foundational pieces within the early ages of 0 to 3 and 0 to 5. And I'm going to highlight some of the work of NOLA Cares that we're doing now. So just to give you some of the context, we are working specifically with childcare providers here in New Orleans. And I want to focus on the child caregivers, and I really want to center them in this conversation. Most conversations about education directly focus on the children, and they don't focus on the fact that we need a qualified, well taken care of workforce in order to be in the classrooms with the children. And so I want to start there, because if we don't have them, then we don't have an educational system. So we're going to really center the caregivers here. And I have some statistics about the context, but I do want to ground us in the fact that early childhood education is really the industry that allows all other industries to function. If we do not have care for our small children, and there is no public avenue for that really right now, like there are with, K through 12 schools where, it's compulsory education. If we don't have care for these smaller children, it's literally other things cannot function. Other industries cannot function. Early childhood education in New Orleans and around the state is really predominantly staffed by Black and Latine women. So within that pool of women, only 16% of women that work in childcare can actually afford their own childcare. 50% cannot pay for medical expenses. 40% are food insecure, and 30% have difficulty paying rent. So when we're talking about these, the ALICE folks that Melanie brought up, our early childhood educators fit firmly in that bucket. These are some of the hardest working women that you will see. They work for our families every day, and they are just not valued. And so these outcomes are leading to bigger outcomes in our community, as these women are also heads of many households. So here in New Orleans, some of these results kind of trickle down into Black children being 3 times more likely to be uninsured, Black adults being 2 times more likely to be uninsured than whites. And that contributes to a whopping 25.5-year difference in life expectancies between the richest and the poorest communities here in New Orleans, which are really divided along racial lines. And so when we kind of see how when heads of household, especially educators that are, supposed to be the foundation of our civilization and of our city, are not able to really take care of and feed into themselves, it is really difficult for them to be able to show up to work. So we get really, really high turnover. That means inconsistent care, and sometimes that means a decrease in quality of care. And we also just get a lot of exploitation of the field, because it is a business of the heart. But just because it is a business of the heart does not mean that we also need to be giving them what they need to be able to increase the quality for themselves and to be able to build wealth. So one of the interventions that we are involved in now is NOLA Cares Collaborative. It's a collaborative of 12 different organizations in New Orleans. We're funded through an amazing grant from JP Chase. And it's 12 different organizations that span the public and private sector. And some of the interventions that we're really looking at right now is really policy and advocacy for providers to really increase wealth building. So that means looking at wage benefit conversations and credentialing conversations. And just to kind of pinpoint one of the biggest issues that we're finding in terms of access to get resources is that right now in Louisiana, especially in New Orleans, where we have a growing Latine population of women that are caregivers and caregiver providers, we don't have any process to be able to credential them in New Orleans. When we spoke to some folks in the LDOE to access the credentialing program, they don't even have the application available in Spanish, nor do they have anyone in the office that would be able to receive those applications, because we're like, okay, well, we can help translate. We can translate it to you, then we would have to back translate it into English and have to go through a whole nother process. So we don't even have anything in place for those women, even when they have completed their coursework to become credentialed. So that's one thing. Another thing that we're doing is thinking about facilities grants. We do have some money through JP Chase where we are making wonderful processes for early childhood educators to be able to access
assets so that way they can be able to grow their business. A lot of times, early childhood education is thought of as being easy. However, it is one of the things that is so expensive when it comes into actually having to provide. There's a lot of equipment that you need. If your building is not ADA compliant, there's a lot of different licensing needs. So not only do we partner with the mayor's office, but also we are trying to see what kind of facilities grants that we can provide for early childhood educators. We offer CDA credentialing, and right now we are the only ones in the city that do. So CDA is the Child Development Associate. It's the equivalent of an associate degree specifically for early childhood educators. When LDOE was not able to further fund the program for credentialing, and this is one of the only credentials that you can get of this type that would allow you to build wealth and to have higher access to higher quality education for your children and for yourself, now NOLA Cares is the only one in the city that is funding this program. We also offer peer-to-peer supports, because one thing that we noticed is that some of the women were not able, that own childcare provisional companies really are not that skilled or have the knowledge to really carry out a business. So a lot of them were using different practices that in the end will ultimately, have their centers be taken away because of legal issues, because of financial issues that they were not able to stay on top of because the business acumen isn't there, although the skill with children is. And so we have For Providers by Providers as one of our partners that offers peer-to-peer supports for the business aspect of it. So that way women can stay in this business, can be able to grow their business and be able to then expand their businesses and be able to offer more wages and expand that within their own communities. And then the biggest piece, one of the biggest pieces, that's one of my favorite pieces, is also participatory action research with a community of Black and Latina early childhood providers here in New Orleans. And this is where we're really able to communicate an ethos of care. Also have them grow skills to become what we call PAR researchers, participatory action research, as the PAR, so we call them PAR researchers, where they will be researching in their own communities, different things that are of interest to them. And so as they're researching these different things, some of them span the gamut from, mental health conditions for the childcare providers, mental health conditions for their students and families, to being able to grow their own businesses, to being able to really advocate for policy issues. And so we have them investigating these things in their own communities, that they can kind of bring these questions up and join the bigger policy tables by actually having the lived experience of what is going on for them in their lives and being able to attach that to certain policy initiatives. So, so that in a nutshell is what I wanted to talk about when it comes to education, access, and quality. This is a really big issue right now in New Orleans because we do have the millage that just passed last year. That money is starting to come in. We're thinking very deeply about how we're going to be using it, but there's also deeper conversations that are happening on the state level in terms of early childhood education and access that can really change how this can work for us. But again, I do want to say one of the reasons why I decided to focus on early childhood education is because it is the hub, it is the foundation, and they are the childcare providers that do not get the same benefits as any other educators do, which is really causing a huge issue to our entire system.
Dr. Swift, I wanted to holler, but instead of hollering, I did that because, and I'm going to go backwards because I am a person that deeply believes, in fact, as a 20-year public health practitioner, I believe that in order to affect change inside community, you really have to build community capacity. And so to hear you talk about that via community-based participatory research, but also to hear you talk about that via this idea of showing this target population their worth, showing them that they can be entrepreneurs, is something that really speaks to my core as a 20-year public health practitioner. So I just wanted to say that first. So thank you for those things that you're doing. Again, from the work that Melanie talked about to this. I mean, I am just overjoyed to be facilitating these discussions today. I was really taken aback when you stated that 16%, only 16% of these heads of households can afford to pay for the care that for their children. And so that to me, again, that speaks to this need for individuals to take the information learned here today and go and share it with their stakeholders, go and share it with their representatives, so that we could come away from this discussion with some real solutions and how we can affect change inside education and inside the economy. So thank you so much for what you stated and shared today. I greatly appreciate it, Dr. Swift. Next, we're going to talk about the built environment, the neighborhoods. And we're going to have a conversation led by Jamelia Freitman. And she is I haven't seen her in a while, so I'm glad to see you here today. Jamelia is a mom, an impact-driven leader with over a decade of experience working with local, state, and federal public health programs. Currently, she serves as the program manager for the LSU Ag Center CDC High Obesity Program, HOP, which focuses on implementing policy systems and environmental changes to improve the nutrition and built environments in 6 Louisiana parishes with obesity rates of 40%. And so without further ado, we're going to go ahead and have Jamelia come on and share with us.
Thank you.
Thank you.
Yes, thank you. And this is my first time seeing those videos, so I agree that they turned out really well. And I'm happy to lend my voice to them. But I'm excited for the opportunity to share how we are implementing sustainable strategies to remove red tape to improve the built environment through partnerships, evaluation, and community engagement. And so really quickly, for those of you who may not be familiar with all of the things that the LSU Ag Center does or what it is. The Ag Center's mission is to provide the people of Louisiana with research-based educational information that will improve their lives and economic well-being. The Ag Center includes Louisiana Cooperative Extension Service, which takes research and puts it into practice in the communities that we serve. And so based on that, we do have an office or presence in every parish throughout Louisiana. So back in 2014, the LSU Ag Center entered into a cooperative agreement with the Centers for Disease Control, known as the High Obesity Program, or HOP. And so this grant funding is only provided to extension programs. And like you stated, the purpose of the HOP program is to implement PSC strategies to improve the nutrition and physical activity environment. And so for Louisiana, 6 eligible parishes are included in this grant, and they have an obesity rate over 40%. And so over time, we have learned that traditional health education programs promoting behavior change are not enough to move the needle and reduce health disparities. And so what CDC has asked us to do is to connect public health interventions to community development or planning to improve health outcomes. And now public health professionals, like we discussed today, have adopted the social determinants of health framework to advance health equity and reduce health disparities. And so to improve or increase physical activity, CDC is requiring us to collaborate with partners to connect sidewalks, bike routes, public transportation with homes, schools, work sites, and other everyday destinations that we may use. They're implementing master plans and land use interventions. And so what that really means is working with communities to establish new or improved pedestrian, bike, transit transportation systems, so activity-friendly routes that are combined with new or improved land use or environmental design, so connecting everyday destinations. According to CDC, doing regular physical activity is one of the most important ways that people of all ages can improve their health. So active transportation like walking and biking makes it easier for people to fit physical activity into their daily routine. So making the healthy choice, the easy choice, as we have all heard. So communities can use built environment strategies like creating safe walking and biking routes to increase active transportation. And studies show that more people bike and walk in communities where improvements have been made, such as adding safer sidewalks, pedestrian crossings, and protected bike lanes. So in addition, when people move to neighborhoods that are designed to promote physical activity and active transportation, they tend to spend less time in their cars and more time walking for transportation. So to do this work, partnerships are very important for us. All of our programs within FCS, that include SNAP-Ed, FNEP, Flavors of Health, and HOP are using this community participatory public health approach and implementing PSCs to improve health. So we are working with the communities to develop coalitions, and these coalitions are essential for helping our extension agents. So shout out to all of my extension agents on this call. So it helps our extension agents and our team prioritize the built environment projects in their community. Active People Health Louisiana, and really what CDC is Active People Healthy Nation, but they've kind of customized this for us, is their branding for physical activity. And so that really represents their funder, which is a very important partner because they give us the funding to do this work, but they also provide amazing technical assistance to us in our communities. I've also been working with the Center for Planning Excellence, or CPEX, and it's a local planning agency in Louisiana that's based in Baton Rouge. And we've been working with CPEX since we started, so around 2014, 2015, and they have been a huge asset to us. DOTD and the Federal Highway Administration, specifically Safe Routes Program, are the non-traditional partners that we've been engaging to successfully move our physical activity work forward. So data, moving to evaluation. Collecting data that accurately represent rural communities is critical for addressing health disparities. So rural data collection generally tends to oversample easy to reach populations. So that will be people with reliable internet connections, people who can actually show up and attend the community meetings, and people who probably trust the data collectors in their communities. So this method can usually misrepresent the needs and concerns of the community. So what we have done to accurately understand the current needs and behaviors, our team prioritized gathering a representative sample through community-based participatory research methods. So to do this, local data collectors were recruited to go door to door to collect in-person surveys. So we collected about 682 surveys, and through this process, we had an 84% response rate. One of the pieces of data that are beneficial for our program is that about 26 of respondents reported walking weekly for transportation. And this data provides evidence for demand for active routes to everyday destinations. So we now have evidence based on this representative sample. Community engagement is the core of our work, and all of our HOP agents are required to conduct a community forum to determine how the community wants to improve the physical activity environment. We also conduct walk audits, do community feedback events, and demonstration projects. And so in the middle, the picture at the top right, CPEX is actually hosting a visioning session with the coalition. So during those sessions, CPEX educates attendees about complete streets policies, and they lay out these huge maps that the attendees use to prioritize the areas that need improvement. Each community is also provided a complete streets recommendation report based on the feedback gathered during this session, and that information is used to develop the plans. We also leverage or host community events such as health fairs, and we use Play Streets resources to bring the community members out and solicit their feedback for future and current connectivity plans. Doing this helps ensure that we are gathering community feedback equitably from the people that will be directly impacted by the plan changes. We have also developed youth coalitions using the 4-H HYPE curriculum, and HYPE stands for Healthy Young People Empowerment. And so our youth coalitions, they have their own forums, and they conduct their own assessments and demonstration projects, and they also submit their own proposals for the projects that they want to do. So saying all that, although we've done all of this great work providing technical assistance to our target communities to develop complete streets plans, connectivity plans, I really didn't want these plans to just sit on the shelf, because we did find that some of these communities, they did have plans that they probably planned to use to apply for funding, but they just kind of sat on the shelf and collected dust over time. And so in order to ensure sustainability, we needed a way to move towards implementation, and our funding can only go so far. So we can, pay for paint and pay for supplies, but we can't pay for labor. We can't pay to build sidewalks. So I worked with my team and said, can our community use these plans to actually apply for funding or DOTD funding? And so what we discovered is that the applications and match requirements were significant barriers for rural and small communities. And at that point, our next step was figuring out a way to make funding, DOTD funding applications or the application process more equitable. So our PA specialist, shout out to Jessica Stroop, discovered Louisiana had untapped funds designated for communities under 50,000 that cannot be spent due to lack of applications. The high cost of local 20% match for rural communities was a barrier to apply for TAP. Only one rural Louisiana community submitted an eligible application for TAP during the last funding cycle in 2020. So she developed a relationship with the program manager for the TAP program and received technical assistance through CDC from the Safe Routes program to work towards making it easier and more equitable for communities to apply. So after months of figuring out how to make this happen, doing a lot of back and forth, changes to the TAP program were announced at our recent Rural Complete Street Summit that we plan to do biannually. At this summit, community teams, and as you can see there's at the round tables, there's a different community at each table. They received hands-on planning technical assistance to help them prepare to submit a TAP application. The changes to the TAP program reduce the local funding match requirement from 20% to 5% for communities under 5,000 and to 10% for communities between 5,000 and under 50,000. In addition to removing the local responsibility for construction, engineering, and inspection costs for all communities under 50,000. This is a huge policy change. The number of applications from communities under 50,000 increased from 1 to 33 during this year. The application deadline was the end of March. Most of these communities have a majority Black population of between 54 to 82%. So we're also reducing the equity gaps with that. At least 3 of our HOP communities applied. And outside of this, another one of our HOP parishes has received about $900,000 in infrastructure funding from 2 sources. So we are really seeing the domino effect from what we have done. To conclude, I am very proud of my team and the work that we have done to really impact change in Louisiana. And I hope to continue work to reduce funding inequities for small, rural, and marginalized communities in Louisiana. And if you want to contact me, my contact information is on there, and please follow us on Facebook as well. Thank you.
Thank you, Jamila. One of the major takeaways that I take from your sharing is that, you know, there are assets that exist inside the community. Far too often, we really don't understand or we don't appreciate the individuals inside the community who are there ready to do something, the organizations that are there ready to do something. They just need a little push. They need a little bit of parity and inclusion. And so I love this idea. I think you stated taking research and putting it into practice. And I think you outlined partnerships, community inside your presentation, partnerships, community engagement, sustainability, and evaluation. And so, but overall, I love this idea of, you know, understanding that there are assets inside communities, and particularly impoverished and rural communities, and leaning into those assets. So thank you for that. We do have questions in the chat, but I'm going to save those questions toward the end. And so again, thank you, Jamila, for that beautiful presentation about neighborhood and built environments. Next, we're going to talk about social and communities as a social determinant. And the person who's going to be leading this discussion is Cassandra Smith. Ms. Smith is a licensed clinical social worker and a board-approved clinical social worker, credentialed with the state of Louisiana since 2000, and is currently serving as My Community Cares State Director. Cassandra received her Bachelor of Social Work from the Whitney M. Young Jr. Clark Atlanta School of Social Work, and her Master's of Social Work degree from Tulane University. Without further ado, my spouse is a social worker, so I know that they are superheroes. So without further ado, we welcome the superhero, Cassandra Smith.
I don't know if I can speak after that, but thank you. So I'm so excited to be here. I would have attended with this content, whether or not I was on this panel or not. So I really am appreciative of you all inviting me to speak today. So I am here as My Community Cares State Director. My Community Cares is a program under the auspices of the Pelican Center And the Pelican Center is charged by the Louisiana Supreme Court with court improvement. What that means is really improving the child welfare system in how it engages with the court system. So in 2018, the Child and Family Services Review conducted what they do with many states, a Louisiana review. Out of that review, there was a performance improvement plan developed. And so as a part of that plan, the idea was to really hone in and lean in on prevention strategies. And that is preventing children from even engaging and or entering into the child welfare system. So out of that review and discussions, My Community Cares was a response. And so in 2019, there were 4 parishes that were piloted with this program. Those parishes were identified because what we found with the data that was showing in Louisiana was those parishes, and we're talking about neighborhoods, are located, and those children who are being removed and placed into the foster care system were located within the same neighborhoods. And so it's really interesting and eye-opening to see how all of our social determinant sectors are intersecting. And so because we were able to identify those neighborhoods, we identified what we call priority zip codes. So in 2019, there was a pilot program that honed in on 4 parishes. Those parishes were Cato Parish, Rapides, East Baton Rouge, and Livingston. And in those parishes, there were 14 zip codes identified. As a result of what we believe was some of the co-design strategies to strengthen families and support communities, there was a significant decrease in child removals in those zip codes. So as a result, the state, with the help of funding from Blue Cross Blue Shield, Department of Children and Family Services, decided that we wanted to expand My Community Cares. What My Community Cares is designed to do is essentially look for resources in the community, ironically, in terms of what we just discussed, and really help support to strengthen those resources, but also help to support and strengthen those individual families. And the goal, because one of the things we do understand is that poverty is a driver of child removal and child welfare. So one of the things that we wanted to do is address some of these social determinants on a community level and in a community context. And so My Community Cares then expanded into, and is now expanded into 9 parishes. And in those parishes, we have done the same, which is identify those priority zip codes. Those parishes that we are currently expanded into are Livingston, we're still in Livingston, East Baton Rouge, Rapides, Calcasieu, Terrebonne. And so those parishes have now decided that they are going to identify their team leads and their neighborhood leads and their anchor teams. And that's driven by our MCC lead agencies. So what we did is simply help the neighborhoods to determine and get feedback from neighborhoods about who's already doing the work in their areas. And as a program, try to strengthen those agencies and those programs in that area. And so MCC does that through offering what we call parent cafes, which are essentially parent support groups. And these are neighborhood-led, parent-led groups. And in addition to those parent cafes and neighborhood-led groups, we also utilize solution-based case management. So the idea is that in order to prevent children from entering the child welfare system, we have to help to do what we need to do to strengthen those families and strengthen those communities before they have, the goal is before they have engagement with the child welfare system. One of the things that really resonated with me today, because that's the direction and the foundation of who we are as My Community Cares, is not just supporting individual families, but looking to really help to sustain community organizing and activism. So we understand that it's not enough. And some of the things we heard from listening circles and from some of the things I've directly heard is it's not enough to come in and just give people stuff, right? The idea is that we have to work with them, for them to be empowered to advocate for the changes in their own communities. And part of that is helping us to identify all of those resources that are built into the community and those natural resources. And so essentially, we are hoping that we are decreasing in the barriers to accessing that care within the community and those services within the community. And our goal is to also to help to connect the community, because we understand the foundation of our work is the connectedness of community, and recognizing that when one parent or one family can lean on another parent or family, they can recognize that those strengths are there and potentially help to keep kids safer. And in addition to that, we want to make sure that we are protecting and listening to the interests of the communities. We're not coming in to tell those communities what it is that they need. We're listening to communities and helping them to galvanize, to energize, and to try to help to meet their own need. On the state level, my role is to support this work through technical assistance, and my state team has also done a great job and is a part of that work, but it's also to look at some of those systemic areas that we can impact, as we talked about advocacy early on, that we can impact to help to alleviate and relieve those barriers beyond that individual family level. And so we have now launched and done our official launch for the expansion of MCC in March. Our teams and our neighborhood lead teams are working diligently. They have on each parish level 3 staff persons. So they currently have a parish lead, which is a parish director. They also have a connect coordinator, and they have a case manager. In addition to that staff on each of those 9 parish levels, they have neighborhood leads. Those neighborhood leads are also individuals who are compensated. And so those are individuals who are in the neighborhood, advocating in the neighborhood, community members that have hopefully lived experience, some of them with the child welfare system, so that we can have an ongoing impact with them leading the charge. So thank you guys so much. I know we have a little bit crunch for time, but I do definitely appreciate you allowing me to share about my community cares.
Thank you, Superwoman. It's fascinating. Well, it's not fascinating, but it's, to hear that there was an intersection between the social determinants and the likelihood of a removal. That's significant. The fact
Yes.
what it demonstrates is that, all of this lacking, it is a symptom of a bigger issue. And so until we are able to really provide job opportunities in an equitable way, until we are able to ensure that we all have safe communities to live in an equitable way, until we are sure that healthcare needs are being met by everyone in an equitable way, we will continue to have these issues. But I like the solution, Ms. Smith, that My Cares is doing by being intentional. Because for me as a health equity strategist, to undo a lot of what we see happening, the inequalities that contribute to the inequities, to undo that, you have to be very, very intentional. And so to hear the work that you're doing, to me, it is health equity work that is centered in intentionality. And so I applaud that. And so thank you so much for what you do and what you will continue to do for the children of Louisiana and even their guardians and parents. So thank you, Ms. Smith.
Thank you.
Again, I know that there are questions and I'm gonna save those until all of the panelists have finished speaking. And so next, the social determinant that we're going to be looking at is healthcare access and quality. And this session will be led by my friend and colleague, Dr. Donna Williams. Dr. Williams is a professor and associate dean of practice and community engagement at LSU Health New Orleans School of Public Health, and is director of Louisiana Cancer Prevention and Control. She received her doctoral degree from Tulane University School of Public Health and has 30 years of experience in cancer research and prevention and control in Louisiana, with an emphasis on cancers that can be prevented, are detected early and cured. Without further ado, again, my friend, Dr. Williams.
Thank you, Nupcius. I have to say I love going last because all the great stuff's already been said, so I can be pretty short here. I'm glad to be here and talk about healthcare access and quality, and I'm talking wearing my hat of the Louisiana Cancer Prevention and Control Program, but really, it's through that lens that we can look at all preventive care. It's basically the same concept when we talk about any kind of preventive care in our country country. And we really don't make preventive care easy here. I want to say again, at least half of all cancers can be prevented or detected early and cured. At least half. So when we think about it from the cancer lens, half of the cancers that we see could have never happened. So I'm going to start with the detected early and cured piece and really focus on preventive health care, the thing we don't make easy in our world. Thank you, Melanie, for talking about the Alice reports. I have to say I've been a big fan of that report for years, and if you're not familiar with it, I'd encourage you to check it out on their website. And when we think about people in Louisiana and preventive health care, a lot of times, you hear people say, well, we have Medicaid expansion. We have a very small percentage of the population that's uninsured now. Why can't people access preventive health care? And the Alice report really says it all. That half, actually 51% of the people in our population in Louisiana are either Alice families or in poverty, which means they live one paycheck away from economic disaster in their family. So even if their health care is covered, we're talking about people who work and work really hard, and we're expecting them to take off from work to get this preventive health care. And in some cases, in the world that I work in cancer, if we want somebody to go get a colonoscopy, well, they're going to be sedated. So that means two people have to take off. Them and someone else has to take off from work for them to get this preventive care. And they take off from work and they don't get paid. So how can we meet people where they are in terms of being able to make these services available? And there are some things you'll see on the slide, some things that we've tried to do in Louisiana Cancer Prevention and Control, but there's so much more that's waiting to be done, and so much of it is at the community level, such as alternative hours, later hours, Saturday hours, when working people can get to preventive care. Getting the care close to home. Right now, a lot of our care is centered in the metropolitan areas, and a large proportion of our state is in the rural areas. And so that makes the taking off from work part even greater, because they have to go long distances and they have to have the transportation to do that, to get the care they need. So how can we work in partnership with some of these large metropolitan health systems to bring care into rural areas, or bring care to even communities in metro areas, bring it right into the community where it's easier to access, and folks don't have to jump through as many hoops to get this care that will in fact save their lives. And then how can we combine visits? So some of the things that we've done is we've helped start a training program within the dental school that every dental provider gets trained on HPV. And HPV causes a number of cancers, most commonly cervical and head and neck cancers. So if someone is going for dental care and at the same time can get information about HPV, and even maybe definitely an exam, an oral exam for oral cancer, and maybe even a vaccination, or get referred for their vaccination to a pharmacy, get a prescription for the vaccination for the pharmacy, and that way don't have to make another visit to get this kind of care. We see the same thing with what we call flu fit. When people go to get their flu shots, can they get the FIT test, which is a test for colorectal cancer? And just how can we combine as many visits as we can so that people don't have to make extra visits for preventive care, which again, take off from work, you don't get paid. And I'm going to do a little commercial here right now for paid time off. Why we don't have paid time off for simple preventive care. The economic benefits of that are so great. And I'm going to encourage people to check in with Louisiana Public Health Institute, our friends there. They're working with a coalition that's going all around the state to really help promote paid time off for preventive care. So check in with them, see what you can do with your community around that, and just any ways we can think of in our communities just to make care more accessible, easier to get to, and make it so that folks don't have to choose between paying the rent or paying the electric bill and being healthy. And then the other piece of for cancer is, besides early detection, is prevention. A number of cancers can be prevented through healthy lifestyles and what we call modifiable risk factors. And again, I'm talking through a cancer lens, but really these modifiable risk factors cross a number of diseases, because we're talking about smoking, we're talking about nutrition, we're talking about obesity and exercise, and these some of the other diseases that are large problems in Louisiana that lend themselves to prevention through these modifiable risk factors include, cardiovascular diseases, diabetes, hypertension, asthma. So any number of diseases have these same modifiable risk factors. So promoting these healthier lifestyles is just going to be across the whole spectrum of disease prevention. So that's really where, I don't have to say much here. And like I said, I like being at the end. I don't have to say much, because you saw the video about the Healthy Communities Coalitions and the community grants to help with things like parks and SNAP benefits for farmers markets to make fresh fruits and vegetables available, and smoke-free programs. And these are available to all of our communities in the state. We do have a competitive process, but we want to make that easier for communities to access these dollars and to work with us to help put things in place at the community level. And so, stay tuned, because we very shortly are going to have some webinars training on our grant process, and also going to have some office hours available where folks can get help writing their proposals, because more than anything, we want to get these dollars out to your communities so that you can make changes in your community. And we all know that no one really wants to get sick, and it behooves us to work in our communities to make the healthy choice the easy choice. And, community really is the central level of intervention here for us.
Thank you, Donna. I just want to make sure I heard you correctly. Half of the cancer that happens in the state can be prevented and cured.
Can be prevented or detected early and cured. So for example, yes, we don't have prevention yet. Hopefully one day we will for breast cancer, but a breast cancer that is detected at an early stage through mammography, 95% curable. So 95% of the people who have early detection of breast cancer will be completely cured from that cancer and not have to worry about it again. So it can either be prevented or they can be detected early and cured.
Thank you, Donna. I also love the fact that you talked about, we are aware of the gaps. We are understanding that, and you said earlier, that a lot of the resources are in metropolitan areas, and we know that there is more that needs to be done in those rural areas. So I thank you for one speaking, but also in the last portion of your presentation, you talked about, grants are going to be coming, and we are going to get down in the dirt with people to help build their capacity to apply for these grants. Again, health equity, that's health equity at work. That's understanding that, I have individuals, I just can't invite people to the table without giving them the tools to understand how to sit at the table, how to engage at the table, how to bring others to the table. So I greatly appreciate the intentionality of the work that you're doing to make certain, one, that people are aware of the resources, people are utilizing resources, but that we're bringing more people to the table to have a part to play in reducing the health disparities that we see inside our state. So at this time, I'm going to open it up for questions. And I think, oh, that's my friend, Dr. Holcomb. Dr. Holcomb, you asked a lot of questions. I think these questions were before me. I hope you're doing good, Dr. Holcomb. I hope, so I think this one might have been answered. Jamie, I might need you to help me with this. Because I don't want to really have a discussion and do the chat. I'm just going to be honest. I don't feel like doing all of it.
I'm here.
Okay, thank you. But I have some questions, and I'll start with, well, there was a question earlier, Jamie, you might have to help me with this one. I think it was for Alice. It was something about Alice. Let me go back up.
Let me go back. So we have an Alice question. When an Alice household is identified while collecting social determinants of health data, what resources in Northeast Louisiana are available immediately to assist the families while the family is looking for a long-term solution? So that might be an additional person that can answer in that specific area, but I'm trying to locate Melanie.
She might have signed up. I see her, but she might not. She might be away from her desk.
Okay.
So we're going to hold off on that one, and I'm going to go to some questions that I'm going to. If you don't,
I'll just jump in for a second.
Oh,
I don't want to
done.
speak for Melanie, but I would assume there are United Way services in that part of the state, and that would be a good place to start.
United Way. Thank you, Donna. And so let me go to some of the questions that Jamie has provided to me. How can health providers, and this goes to the panelists, how can healthcare providers better understand and address the cultural and social factors that impact health outcomes in Louisiana? How can healthcare providers better understand and address the cultural and social factors that impact the health outcomes in Louisiana? I want to answer this, but I have some ideas I can share, but I'm not a panelist. So I will leave it up to my distinguished panels to provide a response. And I'm okay with silence.
I think, I know one of the really significant tenets of the work that we're doing, and I know everyone on this panel is ensuring that racial and socioeconomic equity is at the forefront. So when we say that and we have that on our paperwork and our documentation, I think that really speaks to the heart of what that really means to do that. And I think for me, you mentioned intentionality. It's really ensuring that, one, we have accurate data to match the decisions that we make, and that data represents accurately the conditions and the context of what's happening to marginalized people. One of the challenges I've had newly minted in this position is really saying, I want the data to match so that I can make decisions that intentionally point services and barrier reduction to populations that are marginalized. And so I think that's where I start. And then secondly, on a more individualized level, taking the time to just simply listen and ensure that those voices are echoed and paramount in decision-making. And I know that's not just unique to healthcare workers. And so for me, I think I'm making a intentional decision to ensure that as we move into further expansion, as we move into implementation, as we adapt and change programming as necessary, that the voices that are at the forefront are those that represent the communities that we are targeted to serve. So just my ideas about how I think I'm intending to do that or trying to do that.
Thank you, Cassandra.
I think that was great, Cassandra. I think the listening piece is so important. I alluded to some of the systems issues, and there are any number of systems issues, but when it comes down to an individual and their health care, and it's like them and the provider, it's really about that relationship. And healthcare training it isn't like our grandparents' healthcare training anymore. There's more of an emphasis on cultural humility and listening to your patients. There's also, it's starting to look different. Since I think 2016, the majority of more than 50% of people going to med school were women instead of men. And so that whole patriarchal system where the physician knows best and is just going to tell you what to do, I think is slowly changing. And, you know, for the individual patient, we can encourage them to speak up, to ask questions, to know that they can, you know, be an active part in their health care. And then for the providers, that constant reminder that they may know a lot about medicine, but they don't know a lot about the person that's sitting in front of them, and they need to listen.
Totally agree with that, Donna. Totally agree with that. And you know, I know that I might be coming from a place of privilege saying this, particularly since I know that in rural settings, you know, people, when it comes to providers, they're kind of placed in a situation where you get what you get. But I still think it's important to the point that Donna was making, to say, you know, it's okay to let a provider go if they're not meeting your needs. And I don't know if we share that enough with people in our community to say, you can go to another provider. You don't have to necessarily choose this one. And again, I know that may be coming from a place of privilege, but I do think it's imperative that populations who have historically been stigmatized and discriminated against, they need to be made aware of that so that they can make a strong choice and decision inside the care that they're getting. Next question. What can communities do to improve transportation infrastructure and access to healthy food options and physical activity? What can communities do to improve transportation? And this is going to be the last one. I have 1 minute left and I have to close this part of the session down. I see it's 3:55, but what can communities do to improve transportation infrastructure or access to healthy food options or physical activity?
I guess I'll take a stab at this question. I think it's not just communities, but community leaders and elected officials specifically, because we have to have their buy-in and engagement in order to do anything related to physical activity and in the communities that we work in. And I think specifically for access to healthcare services, especially in rural communities, the transportation is just not there. A lot of people are homebound. A lot of people travel via bike. So I think if there's an effort to work together to figure out how to improve and expand upon the current transportation services that are offered, I know there is a statewide rural transportation program and figuring out how to leverage those resources to expand on that, improve on that, and figure out what other local resources there are that we can use to build upon those transportation services so that people can get to their medical appointments. Because generally in rural areas, people have to drive further to get to work, to get to the grocery stores, to do anything. So I think, you know, being in Baton Rouge or being in New Orleans or a larger city, we do have access to more of that. And when it comes to transportation access, that also impacts your access to healthier foods. And usually the local grocery stores, the cost of the food is higher, the quality is less. And so a lot of our community members, the feedback that we've gotten through some of the focus groups that we've done is they've had to, pay for somebody to drive them to the Walmart. So that may be $20 that is taken out of their budget that could be used for food or other things that they need for their families. And then that's just one way. So you may end up paying $40, to get to the closest Walmart so that you can, leverage the lower prices in the grocery store. So I think that when it comes to access, I think transportation is huge. And figuring out how to leverage the current resources to reduce those inequities would be essential. But it does need to not only come from the community people, the residents, but I think you need that buy-in and from the community leaders and elected officials.
Thank you, Jamila. Our time is up. I'm going to leave you with something that I just referenced to my students in them preparing for their final exam for the semester. And that is that genetics is only 20% responsible for what makes us healthy. Access to healthcare is only responsible for 10% of what makes us healthy. It is behavior and environment that is representative of the 70% of what makes us healthy. And so I asked participants today, you've learned a great deal of information today about how the economy, how healthcare, how education, how the built environment all have a part to play in people's health outcomes. Please do something with that information. Share it with your friends and colleagues. Share it with stakeholders inside your communities. We're not going to be able to hospital our way out of these health disparities. We're not going to be able to federally qualified health center our way out of these health disparities. Those things are very, very good, and they are needed, and we need to get as many resources as possible. But we need to be looking at the social determinants of health and understanding how these social determinants of health are playing their key role in preventing people from reaching and living their best life. Thank you guys so much. I am Earl Dupuis Benjamin Robinson with the Louisiana Public Health Institute and the Louisiana Cancer Research Center. I've had a great time discussing with my colleagues and friends today, and also just sharing and learning information with you guys. Without further ado, I'm going to turn it over to my good friend, Nikisha Singleton.
Thank you, Noopsius. That was an amazing panel, great information shared. I just want to briefly talk to you and touch on the community grants that has been discussed in this last panel. So to help you in your efforts, and this is for all of the community organizations that's represented out there today, to help you in your efforts to combat obesity and tobacco use in your community, the LHCC offers community grants to community organizations working on obesity prevention and tobacco prevention efforts. These grants help to assist communities implement policy systems and environmental changes to increase community access to healthy foods and physical activity, and to increase smoke-free environments. The coalition has funded more than 50 projects in the last 5 years. You'll see a list of the 2022-23 recipients of this year's grant on the screen. This year, I'm pleased to announce that we will be releasing our request for grant proposals during the early summer, as opposed to the fall. We will also be holding grant writing workshops prior to next fiscal year's grant application. So please be on the lookout for communication from us regarding next year's grants and our grant writing workshops. At this time, I would like to acknowledge our Summit Planning Committee for putting on such a wonderful summit. I would also like to thank our speakers for sharing such great information with us today. Before we close today's summit, I do ask that you please answer the final poll question, which I'll put up on the screen in a second, either on screen or in the chat. What is the one key takeaway you will keep from this summit? And we'll put that poll up for you in just a second. And also you have the opportunity to answer it in the chat. So before we close today's summit, I do ask that you please answer the final poll question. And I'll go ahead and release that poll right now. Let's see. So you should see it on your screen. What is the one key takeaway you will keep from this summit? Again, you can answer it on your screen, or you can via the poll, or you can answer it in the chat. As you exit the summit, a feedback form will pop up on your screen as the meeting closes. Please take a moment to complete and submit. And also an email with all resources, links, and speaker information will be sent within the next 2 weeks. So this concludes our summit. Thank you so much for attending. Have a good day.